and welcome everybody to our second webinar in the CAUTI Action Network series. Today we'll be talking about another important pillar of prevention, and that is when inserting indwelling catheters, to insert with confidence. My name is Tina Schween. I'm the Quality Improvement Consultant with Qualis Health, based in Seattle, and I am joined today by my colleague Jennifer Palagi, also a Quality Improvement Consultant, and she's based in Boise. And we're delighted that you're with us today. Just a quick note to some housekeeping. As we move through today's slides, we will have those lines on mute, and we'll be opening up for questions at the end of our two Gus Hospital presentations. We will have folks queuing up to ask questions and participate at that time. Throughout the webinar, if you'd like to chat in questions or ideas or thoughts, feel free, and we'll try to do our best to monitor those along the way. So, as you may remember, this is one of 4 prevention pillar webinars. Last month we had a call that spoke to avoiding unnecessary insertion, and today, as we've mentioned, the focus will be on when you do insert, to insert with confidence and to insert safely. Our call today, our webinar today, will follow a pattern that's similar to what we did last time, and it mirrors what we'll do in the future. We'll kick off the webinar with patient story. We'll briefly touch on best practices that are out there in the guidelines, and then we'll move on to the meat of the webinar, which is really hearing from your hospital colleagues and how they're approaching this particular topic at their facility. We'll then open up for discussion, questions, sharing, and then we'll briefly touch on one of the next series, what's coming next in the series. So, in keeping with our agenda, the first stop is a patient story. Jennifer, I'm going to let you introduce your colleague, Barbara.
Okay, thank you. Yes, we have Barbara Brown on the line from Eastern Idaho Regional Medical Center. And Barbara, I really appreciate you joining us today and sharing a case study with us of a patient who may or may not have had a CAUTI due to insertion practices, but in general, it's good to just start off with a patient story to get us focused on the right thing, the best care of the patient. I'm going to go ahead and turn it over to you to just lead us through this case study.
Okay, thanks, Jennifer. I do house-wide surveillance for CAUTIs, and in my surveillance last month, I had a case that actually became very disturbing to me, mostly because when a patient comes into the hospital very sick, they don't expect to become sicker because of their treatment. If you follow along in the patient's story, just a little synopsis, on January 16th, we had admitted a 69-year-old female with metastatic breast cancer. She was admitted to the cardiac floor. She was very sick, post-chemo, about 5 days, and at the time of admission, she was very hypoxic. She was on home oxygen, had some cardiac arrhythmias, and she was just pretty weak and deconditioned. Looking back at her history, I found that this was actually the second admission for her in less than a week. She had been here previously for a thoracentesis and had a chest tube that was placed for pleural effusion. At the day of admission, it was noted in the nurse's notes that the patient actually requested a Foley catheter, stating it might be a better option due to her extreme weakness. So the nurse obtained an order and placed a Foley. Over the next few days, she actually got weaker and was more hypoxic, having more cardiac arrhythmias. And if you're familiar at all with chemotherapy, usually about 10 days post-chemo, there's her lowest point. And that's right where she was. She was placed in neutropenic precautions, had a very low white count. And her original discharge plans were for her actually to go home about the 19th, but discharge was held because of her decreasing state. On the 21st, she started running a low-grade temp. It was only about 100.5, so not very high, but still was very high flow oxygen requirements, had some hypotensions, and still had some arrhythmias. They did order some cultures, and the urine culture revealed E. coli and Enterococcus faecalis, both with colony counts greater than 100,000. and she was placed on antibiotics the 22nd and finally was able to go home on February 6th. Some of my concerns looking at this is when you have a patient that's post-chemo, you know that they're compromised for one thing, and I questioned the nursing staff whether or not this was really in her best interest, choosing to place a Foley at that time. You know, you can argue that both ways, I know. And then, you know, whether or not extreme care was taken in knowing that she is compromised in cleanliness, pericare, those kinds of issues. Knowing that she's going to be prone to infection, and especially someone who's post-chemo, it's their own body flora that is their most harmful enemy. So those are the things that were running through my mind when I saw this and was disturbed by it.
Thank you, Barbara. This is Jennifer. That's a really great example of a patient story where we get to look at all facets of CAUTI prevention, really. Thank you for putting it that way. I mean, was it even indicated? Were the best practices used in inserting and maintaining it? When could it have come out? So thank you again for sharing that with the group. It leads nicely into our discussion around the second pillar of prevention that you see repeatedly in best practice guidelines, and that is making sure that we're inserting catheters with aseptic technique and standard operating procedures. If you were to perform a catheter insertion shadow audit today in your facility, any of you, what would you find? What do you think you would find? And that's a little rhetorical right now, but we can open that up for discussion later. What are the kinds of practices that you would see? Would you see the best practices around inserting that catheter? So the best practices in insertion technique are going to be familiar to this audience because we have a lot of infection preventionists on the line who know these things inside out. So we're just going to root ourselves in these key things, which is utilizing appropriate hand hygiene practices in accordance with the CDC and WHO guidelines, inserting using aseptic technique and sterile equipment. And you'll see this coming up in the bundles that our example hospitals are going to be talking about. Gloves, drapes, sponges, sterile antiseptic solution for cleaning the meatus, and single-use packet of sterile lubricant jelly for insertion. Using as small a catheter as possible, making sure that the catheter is secured, so there's minimizing any urethral trauma and making sure that we keep a sterile closed drainage system. These are familiar to you all, and we just wanted to touch on them as we move towards our hospital stories. The next thing, too, that we have to consider is the education, training, and continual assessment. And it's very interesting for Tina and I to be working with all of you hospitals and learning what are the practices and what are the education and training practices. And the education and training around catheter care is really all over the map. Everything from, they come in trained on this. We really don't have to do a whole lot more to annual training in some cases. And so I think we'll see as we move along in quality improvement and patient safety that this will probably become more consistent and there'll be some recommendations around it. But you definitely want to make sure that you're training and verifying competency of our clinical staff who may insert urinary catheters, looking for bang for your buck, making sure those places that are inserting them most often in your facility are definitely your leaders in catheter care and insertion. But also making sure that those who are not placing them very often are skilled in it as well. Don't assume that staff hired with previous experience have received appropriate training or are even competent on the proper technique. Make sure you're using some standardized education and training materials. I know Barb will be reflecting on that too in a little bit on Mosby-based education, and so making sure those resources are available consistently across your organization. And then periodic retraining or assessment. How often does that need to be in your facility? So keeping these things in mind as we move along. So now we are going to go ahead and move on to hearing from who you want to hear from, which is your peers We're going to be hearing from two hospitals, one in Idaho and one in Washington, and they're just going to be sharing with you not just what they're doing around insertion practices, because it's hard to pull out just one perfect practice out of all of these pillars of prevention. So you'll see that they have that couched within their care bundles. And so look for the things that might be gaps in your own facility, and we're going to give you an opportunity to ask questions. And until then, if you do have burning ideas or questions, make sure you put them in the chat box. Our first speaker is one I'm familiar with, Barb Boland, who is an infection preventionist at St. Joseph Regional Medical Center in Lewiston, Idaho. And she also does employee health there. And she's going to talk a little bit about the program that they have there. And you'll see over the next few slides, there are just some snapshots of a couple of care policies that they have. So when she gets to those, just know that if you haven't received those in your email for this presentation, you'll receive it afterwards. Barb, I'm going to go ahead and turn it over to you, and feel free to take 10 minutes or so to talk to these folks about your program.
Okay, so I'm Barb Boland. As Jennifer said, from St. Joe Regional Medical Center in the nice part of Idaho. Anyway, so we looked at, several years ago, actually starting back in 2006, we looked at, we've always done housewide surveillance here, so I need to back up there for a little bit. So we looked at that time in 2004, we looked at our BSI rates and we looked at our CAUTI rates, and looked at, based on what the impact would have been at that time, and based on the numbers that they gave you of what that nosocomial infection would cost you, and we went ahead and we presented it at the nursing practice forum to actually apply it to our facility. And just between our urinary tract infections and our bloodstream infections, which, at the time we reduced them considerably, so we considered them to be good, but, looking at that cost, the impact to the fiscal year would have been $2 million. So what we did is we looked at several different resources. Obviously, we looked at like the 5 million K. We looked at the 10 mil. I believe and as newer resources have come out, like when the compendiums came out or whatever the CDC recommendations were, and there really, I want to say there really weren't a whole lot of bundling at that time. So we put our own urinary catheter bundle in there, and I don't know why, but only the purpose and the background are in here. So I'm not really sure what or if all of it was meant to be presented or not. But we did take a look at pretty much all the things that are in all the bundles now. So we looked at hand washing, catheter insertion, the maintenance of the catheter, irrigation, and specimen collection. We presented it at our annual nursing practice forum again, and we went over, we basically went over all the educational components of it. Not only were they presented at that time, but we also had a Mosby-based teaching, computerized teaching that we have, and so the resources in there for being able to tap into the educational component of it, and then there was also a test that everybody had to take, and we did a pre-test and we did a post-test, and I don't have those stats right at that time. But we were able to demonstrate that we went from, basically we reduced our UTIs in the very first year by 60%. So we went from having an average of about 50 UTIs a year down to 20. And we've continued to monitor that, and I put out emails like in the news break, or I send out emails. Right now I know we have the mandatory annual teaching for the BFIs and for the FSIs. Unfortunately, and it isn't really there for the UTIs, but we have been able, because we do housewide surveillance, been able to track and continue to track how our UTIs have decreased. So a couple of years ago, we also tapped into the SCIP measures that looked into, does the person meet the criteria? We aren't completely there yet about whether they can or can't have the Foley catheter, but our skip measures as far as getting them out within the 24 to 48 hours we're definitely good about, because, they say 100% is what the criteria is that you have to meet. So when we focused in on that several years ago, we've actually been able to, in the last 2 years, I can tell you that we had a total of 8 urinary tract infections that were catheter CAUTIs, and this year we are down to 7. And in the last 2 years, we've taken that even a step further to see what the common denominator is. Just like most facilities, I think if you look at where the majority of your catheters are inserted, you can look and see that I think like 35% of them were put in the OR, and another 25% were put in the emergency department. So we would look at that, and we would take we look at that list and say, okay, do we have a common denominator there? And when we've looked at our list in the last 2 years, there really isn't a common denominator as far as where the insertion was placed. Is there a common denominator as far as the floor goes? That was a little bit hard just because we're only 144 beds, and we basically have we have a surgical floor and we have a medical floor. So the majority of our patients are going to go there. And so if you look at the CAUTIs, and that's basically where they're going to be attributed to. We haven't had any, if I can find any wood to knock on, in the last 2 years in our intensive care unit. We also take a look as far as the drill down or root cause, to see is the documentation there to support whether it was secured or not. We also look to see if the documentation that was there to see if pericare was documented. What are the dates that the Foley catheters were put in? And what seems to be the most common denominator about if you look at the risk factors, what are the contributing factors for the most common denominator for why this person could have a CAUTI. And what we've been able to evaluate so far is that the patient usually had that Foley catheter greater than 6 days. So what we'll need to continue to do is evaluate whether that person, did they really meet the criteria for continuing to have the Foley catheter, and for leaving it in. We had a patient who actually went home with one, or another one seems to be that the patient had the Foley catheter taken out according to the skip measure, but then maybe were unable to void and wound up with a reinsertion. But again, the common denominator seems to be that the Foley catheter was left in greater than 6 days. So I know when Jennifer and I had an opportunity to speak about CAUTIs, we, talked about lost my train of thought. But anyway, I lost my train of thought. I apologize. But so when we look at where we've come from, when we first started looking at these, we've had a reduction of 83% in our CAUTIs, which I think is pretty amazing.
Yeah, that is a great reduction, Barbara. And we have some of your story highlights here on this final slide of yours, and I know you've touched on a lot of these. Catheter bundle that was implemented, and folks will have a copy of that policy and the procedure. The online nursing education and testing. I'm not sure if you talked about now what you do, because your events are so rare, how you address those when they do come up, sort of that defect analysis of what do you do when you do have an event, and how does that lead to an improvement?
We do current and, we do concurrent surveillance, and so as they come up, they actually go to the department directors and to the coordinators on the floor, and those reports are given to the floor on a monthly basis so that they can also do an evaluation of a practice. And we, even though I know most people would be really happy to say, gee, we only had 7, and I think that's pretty amazing, but, as I remind people, the target is 0, and so what can we do to even take that further? And Right now, I know there are some things that are recommendations, but, putting up signage, reminding physicians, evaluating the patient. So we have some things that we still definitely could implement that have been there and are recommended, and we haven't really taken them, a complete circle. And sometimes it's really hard, and I think people can appreciate that when you look at how many Foley catheters we have in a year's time, that when you look at adding this much more to the workload already, what would be a simpler way to try to capture these 6 instead of imposing that much more work for, you know what I'm trying to get at. So if you have 10,000 Foley catheters, like, oh my gosh, really? So what would be a different, that's kind of what we're looking at, is what would be a better way to create the awareness and have people take a look at, have nurses looking at whether they meet the criteria. Maybe that would be that, say if this Foley catheter has been in 5 days or 4 days, whatever it is that we decide to that is taking a look at, that might be the trigger then to saying, okay, now's the time to do an evaluation about whether, does this patient meet the criteria? Is there a way? Do we have some other alternatives? I know we've looked at female urinals. We've looked at some of the other options that are out there so that maybe we could do something else to get that Foley catheter out.
Thanks, Barbara. And that does, as we transition over to Luda in a minute, I just wanted to say you brought up a good point that, one of the reasons why I wanted to have Barbara on the line is because they have such a low to, really a zero rate in the ICU. And so that's when you do start asking that question, how many more improvements do I make when we're at zero or near zero? And I think that's where you got to make sure that you have a good defect analysis or case review process in place. And I'm glad you guys are doing that and breaking that down so that when you do have the rare event, you can look and see if there's been a break in the process and see if a process needs to be improved. I'm going to go ahead and give Barb Boland a super big thank you, and I am going to hand it over to Paula Parsons, who is also with Qualis Health, and she's going to introduce Luda, who will be talking with us for the next probably 15 or 20 minutes.
Great. Thank you, Jennifer. Of course, she's practically done the introduction. It is my pleasure to take Tina's place here. She wanted me to pass on. She was called away from the webinar. And with no further ado, I wanted to introduce Luda Lovizinski, if I said that right, Luda. She's a clinical educator at Multicare Tacoma General Hospital here in Tacoma, Washington. And I will go ahead and reduce this and pass the ball to you.
Well, hello everyone. This is Luda from Multicare Health System. I am very honored that I have been asked to participate in this discussion on preventing catheter-associated urinary tract infections and present some of the work we have been doing in this area. This is a very important and relevant topic, as most of us are working on eliminating these hospital-acquired infections, and it's great to have this opportunity to collaborate, share our successes, and learn from each other as we all work towards the same goal. We know that catheter-associated UTI is the most common hospital-acquired infection, accounting for approximately 40% of all hospital-acquired infections. And some studies report that up to 25% of all patients receive a urinary catheter at some point in time, and about half of these are found to not have valid indication. But if indeed the patient meets the insertion criteria and Foley will be placed, it's crucial to insert it in a way that will not cause an infection for that patient. And this is what our topic of discussion is today. So this slide is in honor of a contributor to this presentation, Jeanette Harris, an infection control practitioner at Multicare, whom our success story would not have been possible without. She has been the initiator for the work that was done at Multicare, kept everyone informed on our progress, and has worked very closely with the UTI reduction team every step of the way. she's listening in on a call today, and I just wanted to give a shout out to her and all the work she's done and continues to do. This slide is actually from one of the presentations she's done on the topic, and she kept telling us that zero is possible, and I'm glad we believed her because we have seen the results. So we are a multi-care health system consists of 4 hospitals. We're based in Pierce County. 3 hospitals are in Tacoma, Washington, and one of our hospitals is in Good Sam in Puyallup. We are a not-for-profit organization. The roots of the organization was established here in the community since 1882. We continue to grow in response to community needs, and Multicare is the largest provider of healthcare services in Pierce, South King, Kintap, and Thurston counties. And our model of patient care puts the patient at the heart of all we do. I work at Tacoma General Hospital and provide unit-based education for 5 of our staff, and so today's example will come from that department. So preventing catheter-associated UTIs is a multifactorial approach. Competent insertion is just part of that larger UTI bundle, working towards achieving 0 UTI infections. And we have a bundle of interventions that we have developed for prevention of UTIs, but since our topic today is just on insertion, I will be focusing on that piece of the bundle. FIDAR is part of a TCARE project with Robert Wood Johnson Foundation and IHI, and one of the recommended tools for model of improvement is PTSA cycle. And it's highly supporting the small test of change. So we use this approach when we first looked at the problem with UTIs. P in PTSA stands for planning, and planning ahead for change, analyzing, predicting results. And this actually was done by Jeanette Harris, who identified 5R as the unit that was having more UTIs than some others, and so there was a bigger window for opportunity. These are some of the initial interventions. So we started IDing all active infections at admission, collecting clearance for culture if suspected UTI as soon as possible using the 48-hour golden period. We did not culture everyone, only those that met the criteria. So this led to heightened awareness by all staff. Culture started earlier, antibiotics started earlier, patients were discharging earlier. This increased vigilance for infections, which was a unit-level goal to reduce those. Post-infection rate charts were posted on a unit, and monitoring performance and providing feedback was continuous. And we have seen immediate results after the first intervention. So the results were shared with staff at staff meetings. Information was posted on our education boards. We celebrated. But this did not give us the results that we were looking for because we were trying to get to 0. So we did the process of PTSA once again, and more analysis was done to identify where else can we make a difference. And as a result, a UTI bundle was developed. So a UTI bundle included identifying infections and admission, again, avoiding unnecessary urinary catheters. They all had to be medically necessary, not for incontinence, not for convenience of the nurse. And starting using aseptic technique, and then maintaining catheters based on the recommended guidelines. Included the pericare, using a securing device, and maintaining drainage bed below the bladder. And also review for catheter necessity daily and removing promptly. So the education for our UTI bundle was delivered in these ways. We held in-services with PowerPoint education, and it also included the post-test. We had staff watch a video that was titled Preventing UTI Care and Catheterization Technique. We also held Skills Day, which I'll talk a little bit more about details of it a little bit further. But we had staff return demo to us. We signed them off on a competency. We also looked at each of the occurrences of a UTI and then looked at analysis. The case reviews were reviewed at staff meetings, and this is now a required competency for all new staff. So these are just some slides from the PowerPoint presentation that we had staff attend, reviewing some of the studies and some of the numbers that were significant, and that catheters are uncomfortable for patients. They decrease mobility, which may impair recovery, contribute to other complications. They only need it to be placed for medical reasons, so no convenience goalies whatsoever. And we also reviewed the potential entry sites for the infection. So there are three main ports of entry. 1 and 2 are at the time of insertion, so that's at the meatal and tube junction. So during catheter insertion, the catheter picks up organisms due to either inadequate cleaning, contamination, poor technique, and that leads to an infection. Urethral trauma during insertion can also increase the risk for UTI. And then the last one on there is outlet tube, referring more to maintenance issues after the full cath is in place, with things such as emptying correctly, specimen collection, making sure urine does not sit in the tubes but drains down to the bag, and so on. The appropriate technique for catheter insertion, utilizing appropriate hand hygiene practices, inserting catheters using aseptic techniques, sterile equipment, and specifically using gloves, drapes, sponges, the antiseptic solution, and sterile lubricant jelly. Use as small of a catheter as possible that is consistent with proper drainage to minimize urethral trauma. Using too small of a catheter actually encourages bacterial travel up the catheter and incontinence, which leads to increased bacterial growth, so considering both of these. And have to think hand hygiene. Yeah, I mentioned that, sorry. So some tips to remember that we shared with staff: preparing all items in a box kit prior to touching the patient, using tongs provided, not your hands, when both preparing cotton balls and cleaning patients on initial insertion, obtaining assistance for heavy patients to ensure adequate room between legs, and aseptic technique for cleaning and insertion of the catheter, not inflating the balloon with more than 10 cc of initial insertion, because that can cause further urethral trauma and blockage of the periurethral glands. Testing prior to insertion is discouraged because all catheters have passed QC prior to packaging, and this practice actually creates microtears in balloon fibers that can create urethral irritation and provide places for bacteria to grow. And some of our impregnated Foley catheters, which we have at our facilities, have been proven to reduce CAUTIs by reducing vital inflammation. But a very important point is that nothing takes the place of good nursing and Foley care. So after the PowerPoint presentations and discussion and some case reviews at the staff meetings, we also had a skills lab where staff needed to return demonstrate their insertion techniques in a simulated environment. And so we set aside 2 8-hour days with different start times to accommodate all 3 shifts. Foley insertion and maintenance station was one of some 10-plus stations, don't remember the exact number, that staff were required to complete that day. Unit leadership decided to make these mandatory, which led to higher participation rate. And I would say this is very important to have support from unit leadership for any such project to be successful. We used mannequins for return demonstration. And so not everyone was very excited. The staff were not very excited at that point. We had some rolling of eyes and sighs. Not all, but some people who have been doing this for a while thought this was a waste of their time. People didn't see the value of this at first, but as the education was done and people identified their own errors or bad habits that they have developed over the years, they appreciate kind of relearning this skill. So we identified and addressed some misconceptions and wrong practices. These are just some that we have seen. Inserting a catheter that has been inadvertently contaminated. We've seen people not use all the things that were provided in the kit, such as the cleaning agents, tongs, not using enough gel, or just doing the lousy techniques. Practice of double gloving, so cleaning the patient with regular clean gloves and then putting sterile gloves over them for insertion, and more similar things. I know that some people felt like this was not a real environment and did not feel the need to use up all the cotton balls or put on the drape correctly, but we corrected them and reinforced the importance of the correct practice. I believe that this has led to increased vigilance when they went out and did the skill with real patients in a real environment. During these simulated sessions, we had a lot of discussions regarding evidence-based practice, including no need for testing the balloon before the insertion, not using foliage for convenience, and all the other things that we reviewed in the PowerPoint or reiterated during these sessions as well. So these were just more recently, our kit was updated to include the soap pellets as well as the gel hand rinse, and the sweat sticks instead of cotton balls. And so we more recently did a little bit more education on the topic, and again reiterating the importance of good hygiene and good cleansing and using sterile aseptic techniques for insertion. So this is our success rate, and so we went from, this was intervention 1 back in 2007. We've seen some immediate results, and then more recently, we have only had 1 UTI in the last year, and we are at 403 days since our last UTI post those interventions that we've done. So again, pre-intervention, our UTI rate was 1.91 over in 1,000 patient days. And then current, the most recent data that I had from 2011, that was at the end of 2011, our UTI rate was 0.0215 in 1,000 patient days. So that's a huge improvement. And that intervention provided a 98.87% decrease. And this is just another graph kind of showing you where we were and where we are right now.
Thanks, Luda. This is Jennifer. That is an amazing journey, a great story, and I love how you spelled out all the key practice points that you're focused on. I wanted to first let me go ahead. I was monitoring the chat line, and I see we had a question out there, and it could be for the folks who've been speaking to us, or it could be for other people who are on the line. To answer back into the chat line, but what is your Foley catheter practice for acute hip fractures? Does anybody want to speak to that? Luda or Barbara, or even Barbara, the other Barbara on the line, or any of the other attendees?
Well, this is Luda. For any surgical, we do a lot of orthopedic patients, and our we say 48 hours is our golden period, so we try to remove them before the 48-hour block. The sooner the better, but 48 is like the cutoff time.
Okay, well, let's, I was just taking some notes while you were talking, Luda, and we'll get to this discussion here in a second, because I definitely want to make sure we're getting questions and comments from the other folks. And let me just put a couple things out there. One, I really think that's interesting about the simulations, and those are a growing practice in allowing people to really step in there and practice a skill and try to come close to a real-life scenario. And so I applaud you for that. And it looked like you said you made that practice mandatory. You did have nearly 100% participation.
Mm-hmm.
So that could be something. I don't know if you have a document that describes how you set up your simulation, but it could be something that we'd want to share with the group. And then antimicrobial catheters, always a good topic, because how people use them if they choose to use them. So let's think about that as we move into some of these discussion questions. And we have a good 34 plus people on the line, 35 to 40, including ourselves. I want to think about with just these couple of folks sharing with us their stories. What excites you about what you heard? Was there something in there that you think you could do by next Tuesday? That concept of, well, there is a nugget in there that I could start working on nearly immediately to improve the practice at our facility. Operator Claire, let's go ahead and start taking questions or comments on the line and give instructions for that, please. While we're waiting for some of those questions to come in, this question could be for Barbara or Luda. Do CNAs do your Foley care, and do you educate them on your skills day too? Thank you, Jenna.
Hi, this is Barb from St. Joe's, and I actually was just looking at some of the questions on the chat. So that's a good point. One of the things that we did do is that we did standardize the supply kits with all the necessary items because, it's been a while since I've looked at those, but we did have two different things going on, and so that was one thing that we definitely implemented. Again, we didn't implement the checklist, even though we discussed it. We did have pretty in-depth discussion, but because we were able to demonstrate how much we were able to reduce, again, it's that was considered, to be too labor-intensive if we've been able to reduce it just doing our regular, being able to demonstrate that we were able, by following the bundle, that we didn't have to add one more thing to it. And yes, our CNAs are part of the documenting and the peri-care, and also making sure that they're secured. Although, as far as when they go to do the Foley care, because for whatever reason maybe the secure came off or something, but everybody participates in that, and yes, they are trained.
Thanks, Barbara. Luda?
Yeah, our CNAs have been trained also. We have a competency checklist that we sign them off on as well. So they are actually removing the Foley catheters as well, and they had to demonstrate 3 patient removals before they are signed off as competent on doing that. Yeah.
Very interesting. Thank you. I have a couple more questions on the chat line here. We see... Luda, are you willing to share what specifically you did as your catheter insertion intervention?
Catheter insertion, so we use real Foley kits. We have mannequins, and we actually set up kind of a simulated environment, and staff had to come in and this is your equipment, and this is your patient, and demonstrate how would you insert a Foley catheter. And we were evaluated on how they did. Was that the question? Did I answer the question?
It was what you did as an intervention to improve catheter insertion. So I definitely heard that, the simulation. And then another question we have is for either of you or anyone else who wants to answer, where are you securing catheter devices for male patients?
I can't honestly speak to that. This is for Boland. I can't speak to that. It isn't, I guess I just figured it was always the way we were taught in nursing school.
Yeah.
We secured kind of the same way for females. Males usually have more hair. It's a little bit more uncomfortable to take it off, but it's usually in the same spot on the leg.
Another question I'm seeing, I love that people are putting their questions on the chat. That's fine if you don't want to call in, but I'll check in with the operator in a second in case she is. I'll have her give directions again in just one moment. But a question we have here on the chat is, do you have a competency checklist specific to catheter care?
At the time that we did our initial training, we did have a competency checklist that had to be completed, and it was also part of the Mosby. It was on the computerized Mosby. So not only did they have to complete the testing, and like I said, we did pre-testing and we did post-testing, but a competency list also came along with that.
We have an insertion competency and a discontinuation competency checklist.
I have to get a copy of that. That sounds like something good.
This is Janet Harris, and I just want everybody to understand that Luda did a lot of work observing what the practice was before we did any interventions, because it was very important to understand what was already happening. And we discovered some huge variation in practice. And Luda and the other educators that worked with the staff were able to immediately change that, and make sure that people understood. And it's not always the new nurses who don't know how to put in a catheter. Sometimes the nurses that have been with us for more than 30 years had never had any education or competencies for all of that period of time, and you'd be shocked to find out what you see.
Thank you, Jeanette. And Jeanette and Luda, that just really helped out, too, in thinking, when we reflect back on this slide, what can you do by next Tuesday? So maybe you're not putting in an entire intervention yet, but you simply start exercising an opportunity to shadow or observe what's going on. Maybe pick a unit. And can you tell us a little bit more about maybe how you started doing that? How did you make that comfortable for the staff? How did you implement that? Just in observing them do that.
I think when people started seeing successes, they started paying more attention to it. So the more information we shared with them, and this was an achievement, this is where we were, this is where we are, that kind of excited people. We brought it back to staff. You did it. And Jeanette would come to our staff meetings and she would always say, this is you, this is your work. And I think that's what kind of got people excited, is realizing maybe I was not doing something right. Let's improve my skill. And so I think that exciting people in the process really helped.
One other thing I'd like to point out is we didn't do this as a system-wide big rollout or anything like this. This is something I like to call. Hello?
Sorry.
This is something I like to call guerrilla infection prevention, because you just start small, with one unit or half a unit. We didn't because, as everybody probably knows and has experienced, when you have a huge program that you roll out for not just one hospital, but possibly for a whole system, 4 or 5 or more hospitals, it becomes unwieldy. And so the way we did this was in small groups, and we made small changes and just kept changing, a continuous changing process. And this is where we are today.
Great. Thank you, Jeanette. This is Jennifer, and I love that brings us back to that plan, do, study, act cycle that you were displaying earlier, is that you really do need to start small when you're beginning something like this. And so I would suggest to folks that if you're not sure where to start and you want to take a look at your insertion practices, to do that, to go and start an observation. It could be one observation, and that right there begins a plan, do, study, act cycle of observing what the practice is, reflecting back on it, seeing if they're, comparing it maybe to the process that should be in place, and then trying to make an improvement. And you can make an improvement even in, you can start with a sort of a pilot of one nurse or one part of a unit or something like that. So thanks for bringing us back to that, Jeanette. That's a great idea. I have a question. Everybody is really excited about the competency checklists, and I am too. So we just want to make sure that we can have those checklists shared with us. Would that be all right, Luda, Jeanette?
Oh, gosh, yes. We have a bundle, and we're more than happy to share. We've shared it with the Washington State Hospital Association, and yes, just I'll send the bundle out, and I'm sure Luda can send out the competencies.
Do I send them to you, Tina?
Yeah.
Yes, you can send them to Tina, and we'll get them shared out with the entire group on the phone, and those people who are participating in our projects right now. That'd be great.
Okay.
Did any of you find anything, as we move on in the discussion and start to wrap this up over the next 8 minutes, anything that got in your way, any barriers, any unique barriers that had to be overcome, sometimes there can be nursing pushback, sometimes there can be physician pushback, new nurses, nurses who have been around a long time.
This is Barb again, and I would definitely tend to agree with the statement that sometimes it's the nurses who have been nurses for quite a while, several, a lot of years, that are definitely at times the greater challenge than those who have not been out in the profession that long.
So with that in mind, what do you think is the best way to get over that barrier? Because that's something that people are going to run to in all facilities. I've been doing this for 30 years. I do think one answer to that is that the simulation and making it mandatory for all people is one way to just kind of even that playing field and get them back in and relearning the skills. But anything else that you feel like could help in that particular?
Well, and looking at our facility, we're definitely a lot smaller. So that's why instead of just focusing on when we looked back, and we did a 5-year look back to see if maybe there were more UTIs on the surgical floor than there were in the medical floor versus the ICU, and there wasn't a common denominator there. So that's why the focus just predominantly went house-wide. And, we employ only 300 nurses versus I'm sure you have the other facility over in Washington has a far greater number. So it was easier for us to just, at the time, have the nursing practice form, which we do every year, and be able to roll out the program at that time, and it's mandated by all nursing, and then we gave department directors, deadlines when this needed to be met. And again, agree with the statement that it's pretty amazing what is perceived as being acceptable practice.
This is Mary Sweeney from Swedish Medical Center, and I had 2 comments. One is that I truly believe that the vendors who are pushing the new CAUTI Foley should also come prepared with some educational materials. We had to write our own procedure for Foley catheter insertion and a competency. And I do believe that there's enough literature out there now that some of the vendors, if they're going to give you an in-service on they have all the specifics on how to insert the Foley in a female and none on a male. So we asked BARD if they would be so kind as to create equal gender opportunity for nurses to learn. And the other issue we were dealing with was just the fact that there was huge variance in the way people were putting in Foleys, and most hospitals think that you don't need how to put in a Foley procedure because it's so basic. But if you want to standardize, you have to write one. It has to be standardized throughout your system. So we're finding that that's an important thing to look and see what's available to the nurses in terms of what they have immediately available on their standards procedures, and if that's indeed what you want them to be learning.
Thank you, Mary. Those are 2 very good comments, making sure that those reps are providing the support for the new products that they're bringing to us, making sure that they're in male and female. That's a great idea. And bringing us back home to standardizing the Foley care, and particularly around this Foley insertion process.
Hi, good afternoon. Unfortunately, we got interrupted for a bit over here on First Hill, so if this question was already asked, I'll catch up with that. I work in the PACU area, and there was a webinar yesterday, which all of us were listening to, and they did mention that they were developing explicit criteria for removal of Foley catheters out of PACU before the patients are moved to the post-op units. And they also had there was development of explicit insertion criteria, again, nursing protocols. I just wanted to ask Barbara and Luda if this information was part of their bundle, that the nurse actually would initiate removal or insertion.
No, I tried that one, and it didn't go very far. So it was, and again, we're an extremely small facility, So, for example, we only have one urologist, and it was basically perceived two different ways. One, he didn't want to be told when his Foley catheter should be out that, he wanted to own that responsibility. And two, the nurses didn't want to be empowered and then somebody take it out and perhaps that it was a misjudgment and shouldn't have been taken out. So, again, I come back to even though that is all part of the literature, if we've been able to reduce it by just following the simple things for the bundle, using exactly all the things that have been discussed, using the right size catheter, making sure that they're put in aseptically, that they hand washing, all those things, putting everything in one Foley catheter. Just by doing those things, 83% reduction in 6 years' time, I believe is pretty amazing.
Uda, do you have any insertion or removal nursing-based protocols?
No, they don't have sending protocol for it, but our HUCs monitor our Foley catheters. So on a daily basis, they run like a report to see who has a Foley in place and how long it's been since surgery. And if it reaches that 48-hour, they're notifying the registered nurse taking care of that patient, and then the RN is supposed to contact the physician and say it's possibly time to take it out. So we have that in place, but we don't have a standing order for a nurse to take it out.
Thank you. And we'll be definitely, as we move along in the next two webinars, we'll be addressing maintenance, pericare, and then finally removal practices. Of course, we know all of these are often wrapped up into a bundle, but I just wanted to let you know that we'll definitely seek out folks who have some of these cutting-edge programs or policies in place and hopefully be able to get those in front of you. I know that we are at the hour, so I want to make sure that I honor your time. I want to thank you for being with us today. That next presentation will be next month. I think, Paula, we just had that up. Was that March 16th? March 15th. March 15th, Thursday, March 15th will be our next one. You'll get a reminder to join us that day. And then moving on to the next slide, you have our information here. My contact information in Idaho and Tina's in Washington, and we will continue to work with you. And I'm going to make sure that I get those checklists and those bundles out to all the participants, and we'll also have a recording for this. You will also have the opportunity to do a survey, an online SurveyMonkey, to evaluate how your experience with this webinar format and hearing from your peers, and that'll help us in making improvements where we need to. Thank you for your time today, and be looking for some more contact from us on this topic. Thank you, everyone.
Thank you.
Thank you to our speakers. Thank you very much for joining us today and sharing your practices.
Thanks for having me.